Welcome. This is Combining Social and Media Strategy, a series that explores the new media ecosystem, and we're doing this in partnership with NewsWhip. So I'm Aarti Shah, I'm executive editor at PRovoke Media, and I'm the host for this series. Today is our first episode in which we're exploring the strategies against misinformation, looking specifically at the environment around COVID-19 and vaccine confidence. So on today's show, we have AbdelHalim, who's Crisis Communications Officer for the Africa region at the World Health Organization. And he is based, tell me if I'm wrong, are you based in the Republic of Congo?
Supposed to be, based in Cairo.
Oh, you're based in Cairo. Okay, so you're actually in Egypt. Okay, so my LinkedIn researching was off there.
No, but it's correct. I'm supposed to be based in Congo. Yeah.
Okay.
I'm working from home.
Oh yeah, so yeah, as we are, all are. And then also on the show today, we have the NewsWhip CEO Paul Quigley, who, and I think I'm right here, is coming to us from Dublin, Ireland.
Yep, lockdown in Dublin, not going anywhere.
Yes, and of course, and I'm here in the San Francisco Bay Area. Well, welcome to the show, Halim and Paul.
Thanks
so much for having us.
Yeah, so I want to start by kind of laying the regional groundwork for our listeners. And Halim, I know the African countries are gearing up for the rollout of the COVID-19 vaccine, and from my understanding, this is going to be the largest ever immunization campaign that the continent has ever embarked on. And so I'm curious to hear kind of what role communications is playing in this readiness effort.
Yeah, absolutely. As you said, it is indeed the biggest vaccination drive in not just in the history of the continent, it's in the history of the world. We are trying as much as possible to make sure that to organize ourselves. There's a lot of partners working on this, lots of governments trying to control and not control, but like steer the conversation around vaccines. And of course, there's a lot of misinformation taking place and a lot of misinterpretation. Clearly, lots of information gaps due to the number of uncertainty, the extent of the uncertainty, and things that we simply don't know. We're using a vaccine under the emergency use listing. It's the biggest. We have tried to roll out the Ebola vaccine under compassionate use listing, but it was in specific areas. In Western Africa specifically, but at the moment we are using something that's on a global level. It's very challenging to roll out new vaccines in general. This time it's happening under emergency use listing. It's also happening under very unusual circumstances. We're a global pandemic, nowhere to hide. There's a lot of disparity between rich countries and poorer countries. Self-financing in countries that are part of the COVAX facility, which is the initiative that WHO and Gavi, the Vaccine Alliance, have developed to ensure equitable access of vaccines to poorer countries. So the landscape is very charged, lots of uncertainties, lots of things. The communications role is key in generating demand, but also in a context like ours, where we are facing delays in the vaccine reaching the general population, and we're just purely prioritizing the 3% who are the essential frontline workers and healthcare workers, and then the high risk populations. That has created there's a lot of negative discourse around vaccines, for the obvious reasons, and for sure because people just don't know when are they getting vaccines, is it good or bad, all of these things. But in our efforts, we're trying to create a better or a more positive environment around and a more positive discourse around immunization and vaccines. And we have been immunizing children for a very long time, and it's a very routine thing that's happening in the region. It's just happening, and immunizing adult populations is a bit more complex. And vaccines in general is it has to do a lot with the fundamental values and politics of one person. So demand generation is something that's key, but as I said, creating more positive discourse.
Yeah, no, I think that's a really interesting point because, while you want to build this demand, like you said, I mean, for many populations, the accessibility for the vaccines, we're looking at possibly months down the road. So then you end up with this frustration where you've built up the demand and then people are told, well, no, you actually can't get a vaccine yet. And I mean, and again, I know it's not an apples to apples comparison, but I know even in Western countries, we've seen this. Where the big news in November was we have these vaccines and now it's February and most of the population has no idea when they'll actually be able to get a vaccine. I wanted to talk specifically also about how you all are dealing with some of this misinformation, and I saw that WHO's office in Nigeria actually trained more than 100 national journalists kind of focusing on the principles of public health and sort of understanding the technical terms. So I'm curious because I know so many people who are susceptible to misinformation aren't necessarily getting this through the news. It's coming through platforms like, WhatsApp. So I'm curious to hear sort of how those efforts, it all sort of had a long tail effect to curbing some misinformation on social platforms. And Paul, I know you watch this closely as well, so feel free to chime in.
Well, I mean, our perspective on this. So what we don't get data from WhatsApp, that's end-to-end encrypted, first of all. But what people who are tackling misinformation in Middle East and Africa, who we're working with, often do is look at what's breaking out on public Facebook pages and what stories are breaking there, and that can be an indicator often of what's happening on the encrypted platforms as well. So public platforms can be a good way of seeing what the narratives are that are taking off, and then that could be an indicator of which of those narratives are the ones that we may need to address through a spokesperson, through some public education, through speaking to the media. So I think it's, you can kind of infer and use best estimates from the kind of public data that we gather. We've seen, that being used quite a bit by the people on the front lines who we're supporting. And we've seen as well this quite challenging phenomenon of news stories, anti-vaccination news stories or news stories that are skeptical or that would create skepticism about vaccines going viral and getting a fair bit of engagement in the West. And maybe that's adding to fear and skepticism elsewhere. And I think Halim's you've observed that kind of phenomenon already from speaking to you before.
Yeah, absolutely. I think what we're dealing with at the moment is definitely what WHO had described as an infodemic, which is the overabundance of information around the public health crisis. That's with a lot of misinformation. And one of the things that we're trying to do with WHO is definitely try and address these concerns and these gaps and misinformation. There's clearly a lot of, it's very hard to quantify an infodemic. It's extremely difficult to kind of understand. I mean, the volume of the conversation, that's something that's a metric that we can measure, like a volume of the conversations or the mentions around COVID-19 is something that we can mention on social media. But if we look at exactly what is the percentage of the misinformation that is coming out of it, the technology that we have at the moment is still far away. I mean, and we can get it anecdotally, we can get it through qualitatively, but definitely not quantitatively. And I think the risks of having people, I mean, it is the reality that we're dealing with. People will have concerns, and they are legitimate concerns. It's not everything that is being said is said with the intent to harm. Of course, there are different people who might have different agendas, but some of them are just like, people don't understand the difference between, DNA and mRNA. They sound the same. So maybe, this plays with my DNA. So this is just a small example, but mainly address these concerns and making sure that in terms of people's hesitancy to take a certain decisions around vaccination or not is something that we're trying to build up through, especially for the populations in our region.
That's an excellent point, that a lot of this information is not necessarily with the intent to harm. I mean, there's genuine confusion. I mean, these mRNA vaccines have never been used before. And so, yeah, I mean, sort of meeting people where they're at. You know, one of the things I saw that the Nigerian newspapers were kind of just producing lists of, this is all the fake information, and here's you know, we're going to debunk all of this. It seems like that method of sort of confronting misinformation head on and directly, you know, debunking it, seems like that might be most effective.
I don't know about that entirely.
Yeah, I think,
yeah, no, go for it. Yeah.
Other perspectives there.
Yes. No, well, yeah, no, actually, I want to hear that, because one of the things, Paul, you and I spoke about was, you know, do we giving this oxygen, and if there is a kernel of truth, right, inside of this misinformation, people will grasp onto that and they'll run with it. But at the same time, it just seems like dancing around it can also cause more confusion than addressing it head on. So I'm just curious to hear, you know, do you know how this went in with some of these Nigerian newspapers who publish these lists, and what are some alternatives?
AbdelHalim answer, and I don't know if you can take that, and I've got maybe some data more from the US side I could just briefly share, which might be interesting because it kind of speaks to this problem as well. But
yeah, I think debunking is definitely a very important tool, and we're champions of debunking, and it's something that we're trying to even develop into a brand. As we're trying to work on creating a new brand to kind of address these misinformations and debunk them. However, there is a bit of a science. I mean, it's still, the research is still early, and there's a lot that we don't know, and the landscape keeps on changing. But definitely debunking, there is definitely the concern of amplifying and giving oxygen to the information. It could backfire if the debunks are not of high quality. And when you debunk, it also depends on the format and the messenger, and there are so many different variables. So one Ministry of Health, for example, put out certain messages debunking things, but there were a number of concerns with and a lot of backlash and a lot of negative comments and with those posts. Definitely, it's quite important to kind of create a better environment for people and make sure that the information is ready on hand and accessible, and people have equal levels of information. For example, make sure that the information is translated to the local language, to make sure that the journalists across the region, it's a very big region, Sub-Saharan Africa, and the WHO region for Africa covers 47 countries. 3 main official UN languages, English, French, and Portuguese, and plus the large number of local languages. So there's a lot to work on there. Definitely debunking is one of the things, but definitely there needs to be much more done on that front.
Okay. And to kind of extend the challenge a little bit there, or to kind of bring it back to our side of you know, your side of the world, even, Aarti, like looking at we've been monitoring engagement with the vaccination program from the start of the year, and it's very high. Public engagement is super high in the English language world, or in news content and media output. There's about 25,000 stories a day, getting about 3 to 4 million engagements per day. Huge public interest, and it doesn't spike like most things do. It's just there, and it's staying there. But the most engaged with story so far is a healthy doctor died 2 weeks after getting a COVID-19 vaccine. CDC is investigating why. Now, that's a very factually reported story by the Chicago Tribune, as opposed to, you know, being misinformation. And, you know, it's a balanced report, but the headline would confirm the prior expectations of COVID hesitant vaccine hesitant, or even people who are being disingenuous, you know, will be sharing that headline, and it's a scary headline. But unfortunately, you can't debunk it, or maybe eventually the CDC will issue, and there was nothing to suggest it was related to the vaccine in any way, and maybe a finding will be issued, but it won't get, when the finding is issued, it won't get 5 million engagements like that scary headline did. But it does present a dilemma, because it's a news story from a 150-year-old August publication. It's reporting facts, but then they get interpreted in a particular way. And you know, that means you kind of got to meet people where they are and say, have a conversation about it somehow.
You know, that's a good question. And, you know, that New York Times story, I mean, I'm not surprised that that's been the most circulated, as, I mean, I've seen it many times here as well. So how do you put these numbers into context? I mean, you know, you have, I think as of today, I think over 160 million people have been vaccinated, right? But you know, this one story seems to hit people and stick with people in a way that these big numbers don't necessarily. So how do you put some of these numbers during a pandemic into context? I mean, even the death rate, right? I mean, you know, people in the US anyway, we're at what, I think we're at 500,000 people have died, but people can flip that and they'll say, well, you know, a 1%, you know, fatality rate, you know, what about the 99% survival rate? You know, I think putting big numbers into context is really, really challenging, and it's hard for us to wrap our brains around that. Whereas like one really scary story about a healthy doctor dying, you know, shortly after taking the vaccine, people are able to comprehend. So I'm just curious how you approach that challenge.
I think from our end, I think that's exactly why we work on training journalists, and we're focused on that. And we are in the region, we're focusing on training local journalists, but also globally we're collaborating with UNESCO on that through different modules online that are, you know, at people's space, etc. And the idea here is, again, like the interpretation of the data, especially with COVID-19, it's a full-blown crisis, and you have people who are not necessarily health correspondents covering that crisis. So there is a lot of information gaps about the terminology, how to interpret data, how to which experts to quote, and based on what specialty, and all of these many basic things that are not there. So that's why we're focusing around that. But that said, I mean, going on that example that you mentioned, and this is part of our risk communications. I mean, firstly, there is something like in our crisis communications in countries and on regional level, global level, there is something that we plan for, which is, and not just with COVID-19, with any mass immunization campaign, which is addressing adverse events following immunization. And that's something that is possible. And for example, we had a case in India for polio, where we had frontline vaccinators who just used the sanitizer to the child instead of the polio vaccine. And that's, I mean, these things happen. There is a margin of human error. There's a margin for the people who implement the vaccine, administer the vaccine, and for the people who store it, for the people who manufacture it. And there's definitely a risk in there. And we're talking about millions and millions of people. So it's just, the only thing here is that we need to be transparent. We need to make sure that we address people's concerns head on in the community. And again, these are things that we have on the continent. I think this is something that, with the routine immunization programs, I think this is something that is quite important for communicators around vaccines in the West and the global North. These things happen, and it's the reality. So we need to make sure that when we communicate something, there is no silver bullet. This is and there is no one size fit all at the end of the day. So we're trying to work with a mix of things. Definitely, our biggest challenge is uncertainty, and making sure that we communicate as clearly and as transparently as possible, and to make sure that the population understands the different dimensions of the issue.
On that note, you know, communicating uncertainty, I think that has been a big challenge of this pandemic, as you know, as we're getting data in real time and changing guidelines based on that. And that also seems like that's been an opportunity for people, to discredit people, you know, experts, and also, of course, for misinformation to thrive. So I'm curious to hear from either of you in terms of what you've seen from your data. around how do you communicate uncertainty and how do you say, look, this is the data we have right now, and yes, this could change. Now we have new guidelines, masking guidelines in the U.S. that are different. And I mean, there was a time not about a year ago when we were advised not to wear masks, and if anything, wearing masks was considered to be selfish because you were taking masks from frontline workers. And I was actually talking to somebody the other day about how drastically that changed, right? There was a point where we were looking at people wearing masks and saying, how dare they have a mask? That mask should be with a frontline worker, to now, how dare they not wear a mask, right? And then now this next evolution is, wow, I mean, do we need to be wearing double masks? And for people that understand the scientific process, I think they can follow that logic, but I don't think that's necessarily, we shouldn't take for granted that everybody does or will.
I mean, the only thing I'd say from
Absolutely, I think.
Sorry, Halim, please go ahead. We've got our signals have to travel so far between San Francisco and Cairo and back to Dublin, so it's amazing we can have this conversation. But please go ahead. I'll add a final thought.
No, I just wanted to say that it's something that we struggle with for sure. But at the end of the day, we need to be, the only thing is just to explain that there are the thought process and not just give people decisions. And that's something that when you roll out a vaccine or roll out a specific public health measure, there is a benefit risk analysis for everything. There is a cost benefit analysis for everything to make sure that this is the case.
I've been really impressed. My wife actually works in public health, so she is an epidemiologist, and I've really, from speaking with Halim about all of his work, like there's a long game here of trust. And while a debunk kind of dunking might feel good, there's a long game of trust, and a lot of people who are skeptical out there. And there's a lot more vaccination programs to come in the world, and the WHO is going to be back to have to deal with Ebola after this, and malaria. All right, maybe that isn't a vaccination thing, but there's so many other programs that we need long-term trust for. One thing, like we started monitoring Reddit recently, and I'm really impressed with the transparency and quality of conversation that can happen in groups, including doctors talking about side effects of the vaccine and talking about it openly and acknowledging there were side effects, but this is still the right thing, and I feel safer now, and it's better than getting the disease. And being able to have that 360-degree kind of conversation, but it's very hard. I don't know if the pipes for communication are well optimized for right now.
I think trust is such an important piece to this. And Halim, I'm curious to hear from you, where did you all start from a trust perspective at the start of this pandemic? And how have you seen that shift over the last 12 months?
I mean, generally, WHO's in the region, at least, we are, according to a number of CAP surveys, knowledge and perception surveys, we are definitely the highest in terms of trusted source of information on public health issues on the continent. And the thing is, it didn't really help to have certain heads of state kind of attacking WHO and kind of scapegoating the organization. As much as possible, we are trying to kind of address these concerns on an advocacy level with those heads of states, with those members of parliament, et cetera, and those makers. But I think there is a lot of trust in WHO, and it's something that's seen as an organization that is seen as African as well, because in terms of who is leading the organization, Dr. Chidisi Mwati, our regional director, and all of the different experts who are in the field.
I wonder if we could kind of zoom out for just a moment, because I'm curious. There's something else that I noticed actually when I was going through, some of the WHO's publications recently. And, I noticed that, 2 years ago, the Kenyan government sort of piloted sort of a universal healthcare program, I think in 4 of its 47 counties. And I'm curious sort of if you all sort of had your first brush with a lot of misinformation during that campaign. I know in the U.S., any effort towards universal healthcare becomes breeding grounds for misinformation. I mean, we saw this with the rollout of ACA and death panels, and this was a misinformation campaign before we were commonly using that word misinformation. So I'm curious if you all sort of saw that in Kenya as you all as the government was piloting this program.
This would definitely not be a question for me, I'm afraid.
I know, right? Well, yeah, I mean, I was just wondering if there were other, if other countries sort of face the same resistance to sort of universal healthcare as we do, at least in the U.S.
I think it's an important point, but I think for the moment the different misinformation. Sorry, my door is ringing. Pieces of misinformation that we have and that we're dealing with are related to COVID-19.
Yeah.
And the vaccines at the moment. So that's at the moment, these are the top things that we're dealing with. Definitely, we would like to expand the scope, and that whole idea of the Africa Infodemic Response Alliance, which is an alliance to kind of address misinformation around different public health issues and not just around emergencies. Definitely, infodemics happen around public health crises, but misinformation in general around public health issues and is something that has been around for since forever. But at the moment, I honestly don't have an answer specifically about that example. But for the mere reason that we're focused around COVID-19 and other emergencies.
Yeah, no, I absolutely. I mean, I was just when I was reading that, my thought was, how anything related to public health, how that becomes sort of this magnet for misinformation, and I went right back to death panels in 2009, and then of course the MMR vaccine in the U.S. has just been this magnet for vaccination campaigns. So it just I mean, I think there obviously, I mean, people's health is their most prized, valuable asset, right? So it makes sense that
sorry to interrupt, Aarti, but there is actually, when I zoom out, there is a phenomenon that you're diagnosing there, which is that when groups tend to be susceptible to misinformation that kind of confirms their beliefs, or if their leader says those guys over there are lying, then people will fall in behind and start to believe any story that confirms that belief. So like when we've been looking at the spread of misinformation, it's almost always associated with a group. It doesn't spread randomly through a population. It spreads through groups of people who are predisposed to believing it. And the US is, is severely polarized currently, and healthcare became one of those things. And it's very strange how some things, even scientific questions, once they enter the magic, crazy roundabout of US politics, can very quickly become binary, and then misinformation can come in. As long as it confirms my worldview, it must be right. And I think public health is one, I think more in the US than in countries in Europe I'm aware of, that it's become, and the idea of universal healthcare has become this lightning rod in a way that's difficult to understand for most Europeans.
Yeah. Yes, I mean, absolutely, and it's difficult for even in the U.S. for the two sides to even really try to come together, because one's seems like there's different worldviews in which they're engaging with the conversation. So since we're speaking globally, one of the things I wanted to get, Halim, I want to get your perspective on is the variants, right? And not only is this another area where sort of misinformation can thrive, but also there's issues around how we name them, and sort of what some kind of xenophobia that can be kind of embedded with that of course could lend itself to misinformation. I'm curious to sort of hear kind of how you all are approaching talking about the variants, and if there's a public education campaign around using, whether it's using the technical names or emphasizing that this is where this variant was first identified, but it does not necessarily mean it is a UK variant or a South African variant. It just means that's where it was first identified.
Yeah, absolutely. I think it's quite important to highlight that it is against international health regulations and to kind of name any virus or any variant by the location it was first identified. And we say identify because it's different from, we say identify, not emerge, because we would know that it had been first identified in that location, but we wouldn't know where exactly it first emerged. And there's always this, again, talking about our uncertainty, definitely talking about the technical terms. That's the most important thing. And that's what we're trying to do in all of our public communications, saying, for example, we say the 501 V2 or the 501 variant first identified from South Africa, not the South African variant, or not the first emergent in South Africa. That, and just leading by example and kind of guiding journalists that we train and that we brief on that all over language, on social media, etc. I think it is actually quite an interesting idea to kind of explain and to do a communications, especially about that. There was, we haven't done something like this, but it's kind of one of those things when, if you remember, the coronavirus was first called the Wuhan virus. That's something has barely anybody mentions now. I mean, unless somebody insinuates on this specific topic or this specific thing. But throughout the period of the pandemic, this is something that we moved on, and we're positive that this is going to happen as well with the 501 variant that was first identified in the UK and South Africa.
So, yeah, so when I know we have to wrap up, but I wanted to maybe this is ending on a good note. But we talked about how social media has sort of accelerated and intensified the spread of misinformation, but it also seems like it's been this opportunity to communicate nuance that may be difficult to do so, just simply through the mainstream media channels. Things like, how to properly name the variants and what the differences are between being identified somewhere first versus emerging somewhere. And do you feel like social media has actually been a tool to be able to communicate some of these nuances in this pandemic that maybe without those platforms, it would be more difficult?
Like, I think when look at what's being getting the most engagement again, like, first of all, the direct channels have been there, like the WHO and UNICEF have by far the most engaged posts on Facebook. And in fact, after that Chicago Tribune story I mentioned, the second most engagement story about the whole vaccine trial is getting COVID-19 vaccines to West and Central Africa on unicef.org. So the direct channels are there, which is brilliant, in a way that wasn't possible before. There were these demand aggregating social networks. And the other thing is an opportunity to tell hero stories from the other side. There can be a one-person scare story, but then you've got the story, an all-female team delivers COVID-19 vaccines in harshest of conditions in rural Alaska. So you find the heroes and those stories from the other side, and those can be important counterpoints, and they can personalize and create the stories that are optimized to get a different kind of message out on social media.
Mm-hmm.
One last thought, the fact that we're able to quantify the reach of this is on its own is something that is quite important to acknowledge. From the power of understanding the power of these channels is quite important, but also imagine amplifying this and trying to quantify if we work in a consortium or in an alliance format, like what we're trying to hope and do with the African Epidemic Response Alliance. We're trying to make sure that instead of reaching through just the WHO account 10 million people, we want to reach 50, 500 million people, and to be able, through amplifying and making sure the message is resonating and is going from one place to the other, through definitely trusted sources, and people are having this interaction and engagement with these messages.
Mm-hmm. That's a good place to stop. I feel like many of these threads of this conversation could be its own discussion. So maybe we'll have to revisit this at some point. But for now, thank you, Halim, and thank you, Paul, for your time today. And of course, we'll be back with another episode of Combining Social and Media Strategy soon.
Thanks, Aarti.